also actually a great cup of coffee. I don't know where they made it, but it's in the kitchen probably. In any case, today's topic is why do you have different sizes of incision in surgery? And we're talking particularly about spine surgery, but it really pertains to all surgeries. Why are there different size incisions in surgery? Well, the short answer is that the incision is as big as it needs to be, right? So you can do what you need to do, but there's more to it than that. Any incision that you make, even a needle stick for that matter, causes trauma to the body, to the skin, to the tissues below, and so on. And that type of trauma, more than simply just hurting, even if you're under anesthesia, that causes a physiological reaction. So that, in other words, the body reacts to that, releases cortisone, and there's other reactions, and affects blood pressure, it affects other things, and so on. And certainly an incision is bleeding, will also have other effects, a loss of blood, and so on. So there are effects to an incision any incision you may make, a needle stick you may make, any trauma to the body, whether you're awake or asleep under anesthesia. And those kinds of effects, can be problematic. They can cause other problems. People can have other issues under anesthesia because you're stressing, the body. So you want to minimize the amount of tissue trauma. So you don't want as little tissue trauma as you can, as little bleeding as you can, because the less bleeding, the less trauma, the less stress to the body, and so on, and the less problems and complications you can have from any given surgical procedure or even injection. So why do we have different sizes then? Why not make it the smallest possible size that you can? There's less tissue trauma, there's less bleeding, and that would be beneficial. Well, the answer is that the size of the incision is dictated by what you need to see. It's sort of obvious, but maybe not so obvious, that a surgeon needs to be able to see what they're doing, be able to see well so that they can do what needs to be done and accomplish the goals they need to accomplish, whether it's removing a disc herniation or fusing a spine or any surgery. Over time, we've started using small cameras and small cannulas that we can see through. In the past, you had to make an incision to be able to see what you're doing. And bigger incision, you can see better. So you need an incision small as you can make, but as large as you need in order to be able to see what you're doing. As time went on, there were things like loops, where you put these glasses. They have little magnifiers on the glasses. They're called loops, and they're quite expensive. But you can see better. You'll be able to magnify your vision 2 times, 3 times, up to almost 6.5 or more. So you're able to see. And some of these long loops they had. Then we started to use microscopes. And I use microscope in the operating room for different procedures, where you can see even better. So presumably the incision can be smaller and smaller because you can see better. With endoscopic surgery, for example, you have just a very small incision, so that you can go down and again, see what you're doing through a small camera. And sometimes with injections, we just use fluoroscopy or X-ray, so we can see the point of the needle under the X-ray machine, and that's maybe enough because you only need to see where the medicine is going, to see the underlying injuries or pathology. To do something about it. All you need is to get medicine nearby. So we're on it. So the size of the incision is dependent upon being able to see, and the instruments that we have are designed to make the incisions smaller and smaller, so that there's less tissue trauma, but we can still see what we need to do. So the incisions are different sizes because you need to see what you need to see, and the technology is what it needs to be in order to see. Now, that being said, there are still some incisions you need to make, larger, because you have to do something. For example, you may have to put in a screw or a cage or a plate, like on the neck. You have to make an incision big enough to get the instruments in. So it can't be tiny, tiny. It may have to be a little bit bigger. And there are times you have to do multiple, different levels and or a bigger procedure. And you just can't do that through little small incisions and putting a camera here and there. You got to be able to see, what you're doing. The goal, though, is to make the smallest incision in order to accomplish what you want to accomplish as quickly as you can or as efficiently as you can. You don't want to be under a small scope for 6 hours when you can make an incision and get the procedure done in 45 minutes. So it's a balance, but you do want to make the incisions as small as you need to make in order to accomplish the things you want to accomplish in a quick and efficient and safe manner. So that's why we talk about minimally invasive surgery. There really is no definition for minimally invasive surgery. It's a bit of a marketing thing, but the idea is make it as smallest incision as you can in order to accomplish the things that you accomplish. I do have people come to my office saying they had minimally invasive surgery and they have an incision. And I was like, okay, well, maybe it needed to be bigger and they able to do it smaller, so they're calling it minimally invasive. But in any case, the idea is minimum tissue trauma, minimum stress to the body. The recovery is better with less bleeding and so on. As long as you can, see, what you're doing, and you can get the instruments that you need, in where they need to be. If you need to put instrumentation, in the spine. Certainly, if you need to remove, some type of large tumor, there's some other kind of surgery, not spine surgery necessarily, that I do. Then the incision has to be big enough to get it out, essentially, unless you can remove it in small pieces. But generally, you'll have to make a larger incision. But that's the reason there are different sizes in order to be able to see what you need to see. Being conscious that you try to make it as small as possible, but not in a way to make the surgery so long that it just takes too long for the procedure, because that in itself is a stress to the body and it leads to problems, complications, and so on. So that's sort of the short and longer answer to that question. So I'm open up the floor or the intranet, whatever that is, to additional questions. If anyone has any questions about incision size and surgery, spine surgery particularly. I can read it. The larger wounds take longer to heal. In a way, yes, and in a way, no. Incisions heal, from side to side. You learn that in medical school. You make a little incision, it still heals side to side. Make a long incision, still heals side to side. So therefore, it's going to heal at the same rate in any given part of the body. For example, in the spine or the knee, before it really is healed, it's about 2.5 weeks, something like that, for the scar is tight enough that you can move around. However, in different parts of the body, heal faster, like the face, it maybe 5 days or less. So it depends where it is. But the incision size in that area of the body heals side to side, doesn't heal the length. So a longer incision, twice as long, doesn't heal. That small incision twice as long doesn't take twice as long to heal. Heals at the same rate. However, a longer incision, there are more things that can go wrong with longer incisions. So, if you have healing or a problem with the incision, doesn't heal quite right, well, there's more to heal. So it's potentially, you may have a problem at the bottom of the wound, at the top of the wound, because I'm more of a wound that can get infected or broken down in some way. So that may lead to a longer healing. So smaller incisions are more likely to heal the way you'd expect than a longer incision. Plus, in fact, longer incisions may have more bleeding, in which case you have other problems potentially with the wound. But from the healing standpoint, they heal at the same rate technically. Let's see, any other questions? I'm reading them today. I can see them monitored today. Let's see. No, I think I don't see any other questions here about. Oh, there is another question. Let's see if I can read it. Hold on. What's the difference? What's the difference between sutures and staples for healing and scarring? Well, that's a good question. Sutures and staples. We want the wound to close, right? You want the wound to be closed. Unless it's a very tiny incision or a needle stick, you can put a Band-Aid on it. When you make an incision in the body, the skin is separated, right? And it's very, very small. It'll just flop back together. Like a needle stick. But if it's an incision, the pieces are separated, and you want the pieces to come together so that it'll heal, side to side healing. And there's different ways to do that. There's sutures below the skin and in the skin. That's one way to do it. Another way to do it is staples. You can staple the skin, closed very, very, quickly and efficiently. And sometimes you just sort of steri-strips or Band-Aids along the skin. It depends a bit on the area of the body that it's in. Sometimes those little Band-Aids in areas that are sort of sweaty doesn't really work well and they fall off. So you have to do something else. But one of the ways we do it is we make the incision and we close the skin below with sutures below the skin. And at the skin, it's basically virtually touching. So we put some Band-Aids across there, little steri-strips, not really Band-Aids. They close the gap there, and that'll give sort of a straight incision, scar, I should say. You can close it with sutures, and suture and suture. And there's reasons to do that, particularly if you think there's going to be a lot of bleeding or something. You want to make sure the skin stays closed. That will work. And staples is a very quick way of doing the skin closure. And you can also staple it. Why I would use staples versus sutures? There's technical reasons why one versus the other: the area of the body, the amount of bleeding, how deep the wound is. There's things to think about, deep the wound is. But generally, you can almost use them interchangeably. One of the challenges is with sutures in the skin or staples in the skin is you have to take them out. They have to come out once the wound is healed. So that can be a bit challenging for patients sometimes trying to remove them, but it's not too bad. The scarring you'll see, you have another break in the skin, whether it's a suture or whether it's a staple, you have another break in the skin. So you'll have more potential for scarring there. So you have the incision scar, and you have little dots for the suture or the staple next to it. And sometimes people don't like that. I try to avoid that. I like our incisions to look nice, but you can do it that way. And sometimes it's efficient. So for example, if you have a longer incision and you've been there quite a while, you might not want to have the patient under anesthesia for another 20 minutes or so while you're slowly suturing one by the, so you just staple it and it's done in a couple of minutes or a minute. And that's much more efficient, much faster. And there's advantage, to doing it that way. Generally, though, I think most surgeons, certainly in the neck, they use sutures or below the skin and Band-Aids, that kind of thing. Not much suture in the skin. But those are the different ways to close things. And there are different techniques for different kinds of wounds. For wounds that are elective surgery, people don't have a terrible infection or something. You can you do more of a nice closure, so a nice little scar or a nice straight scar. When you have deeper problems or bigger issues, and you just need to get the wounds closed and make sure they stay closed and heal well. Not as concerned with aesthetics for that, and you may use sutures and maybe staples in those situations. That I think is a fairly good answer to that question. Let's see. Any other questions? Oh, let's see. I don't know. Could be. Maybe they're thinking. There's a lot of thinking going on. I can feel it. Well, the reality is, if you have any additional questions, you can email, and we'll answer those certainly by email, and no problem. And if there are any other topics, and we have a list of other topics, we're working on them this morning for future coming lectures, or not really lectures, talks. Feel free to ask. I mean, there's no stupid questions. If you don't have the answer, we can maybe provide that answer in either one talk or put it into another talk. I think somebody asked a question. I said, it's a good question, but it's not big enough for a 5, 10, 15-minute talk, but we can add that into another talk, and we can answer that question in the context of something else. So feel free to ask your questions, and we'll answer them directly to you, and we may incorporate them into some future ideas and things that we can talk about going forward. Let's see, make sure there's nothing else. If not, we will sign off for today. And I think we're doing this again next week. I think the holiday may interfere with one of the talks, but we'll be sending that out so everyone knows. Thank you very much. I'm going to finish my coffee at my desk, and till next time, Dr. Arvenucci for Arvenucci Medical. Have a great afternoon.